So this is going to be the first of two set of slides comprising the intrinsic renal diseases as opposed to the post-renal and pre-renal. What we have in the tubulointerstitial disease and in the glomerulonephritis is a very wide range, a very diverse range of illnesses. So it's best to think of these as two different classes that have similarities, but each different pathology is different and has different aspects. So don't think of these necessarily as two homogeneous classes, but as two classes that each have their similarities within each respective class, but really have multiple pathologies that are separate. So first we're going to talk about the tubulointerstitial disease. And tubulointerstitial diseases are in general the diseases that affect the renal tubules and the interstitium. So this is separate from the glomerular diseases, which is where the problem is in the glomerulus itself. Tubules are responsible for concentrating the urine. And so when we look at the urinalysis in any patient with tubulointerstitial disease, we're going to see problems with the osmolality and sodium abnormalities, but we're not going to see real big changes in protein. We're not going to see elevated protein. We're not going to see elevated red cells. Those should be normal. So the main problem is going to be in the osmolality and in the urine sodium. So this is a reduction of tubular function or interstitial disease, and both are going to result in impaired resorptive capacity. Try saying that 5 times fast. So remember that with the pre-renal and post-renal disorders that we had increased resorption because we either wanted to resorb fluid or we wanted to decrease back pressure. With tubulointerstitial disease, we actually cannot reabsorb, and so the impaired resorptive capacity is going to be what affects our osmolality and our sodium levels in the urine. So we have what's called isostenuria, which is a big word, but what it basically means is that the urine osmolality is roughly the same as the blood osmolality, and it's less than or approximately equal to 350. This is going to be a key finding in tubulointerstitial disease. Remember that in the pre-renal failure and post-renal failure, the urine osmolality was high. In the tubulointerstitial diseases, the urine osmolality is going to be low. Why? Because the tubules are damaged. And if the tubules are damaged, we can't concentrate urine. So the urine osmolality is going to be low. And the urine sodium is going to be high because we can't bring that sodium back from the tubules into the bloodstream. So unlike in glomerular diseases, which is the other intrinsic renal failure, renal biopsy is not used for diagnosing the tubulointerstitial diseases. So when we talk about the glomerular diseases, we're going to talk about diagnosis, and renal biopsy will play a prime role in diagnosing glomerular diseases. Not so in the tubulointerstitial diseases. We rely primarily on the urinalysis. So this is just a slide comparing the tubulointerstitial and glomerulonephritis. So one big thing to remember is that the urine osmolality in the tubulointerstitial diseases is going to be roughly the same as the serum osmolality, and that's because we have no reabsorptive capacity when the tubules are diseased. The urine sodium, therefore, is going to be high because we're not reabsorbing sodium. It goes out in the urine. Big thing to remember, though, is the debris. So the debris is muddy brown casts in the case of acute tubular necrosis, eosinophils in acute interstitial nephritis. It's pretty rare to see hematuria and proteinuria in the tubulointerstitial diseases. Usually that comes with the glomerulonephritis. The causes of tubulointerstitial diseases are vast. Concomitant illness can be there. Drugs are more common. You can have various infections. So such drugs can be NSAIDs, it can be sulfas, and then certain illnesses that can cause
Interstitial nephritis can be things like leptospirosis, CMV infection, Legionella, rickettsia, strep. For diagnosis, the tubular interstitial diseases, we rely primarily on urinalysis and history, and the treatment is going to be supportive. In severe cases, we may go on to provide dialysis, generally if the patient starts to show signs of uremia. Now, with the glomerulonephritis, you'll note some major differences. You do find blood and protein in the urine more often, and the causes with the glomerulonephritis are often congenital or autoimmune, and the diagnosis, the most important step for diagnosis is going to be the renal biopsy. We don't do that for the tubulointerstitial diseases. And for treatment with the glomerulonephritis, we often give steroids or immunomodulators. That's much more common, whereas with the tubulointerstitial diseases, it's much more often going to be supportive care.
So we can see here, this is just a diagram schematic of a nephron. And this here that we have is the glomerulus. So this is going to be affected in the glomerulonephritis. And in the tubulointerstitial diseases, the place that's going to be affected is going to be the proximal convoluted tubule, the distal loop of the loop of Henle, the thin and thick ascending loops of the loop of Henle, and the distal convoluted tubule. So we can see here that what the primary function is water reabsorption and sodium reabsorption. That's going to be impaired in people with the tubulointerstitial diseases. In the glomerular diseases, what happens in the glomerulus is we get a filtrate of water, sodium, potassium, chlorine, bicarb, urea, glucose, drugs, and proteins. Protein and red blood cells are going to come out of the glomerulus in the glomerular diseases, and they're not going to be reabsorbed because in our tubules we can't reabsorb such large things. And so that's why we see protein in red blood cells in the glomerular diseases, but not in the tubular diseases. In the tubular diseases, we're going to see defects in our reabsorption of water and sodium.
So looking at our labs, we can surmise based on what the loop of Henle does, what these tubule cells do, which is primarily reabsorbing water and reabsorbing sodium, that our urine is going to be high in sodium, because if you think about it, the tubules are supposed to reabsorb sodium into the bloodstream. They don't function. You end up with more sodium in the urine. So you have a urine sodium and a fractional excretion of sodium that are both high. Remember, these two just follow one another, so they're always going to be either both low or both high. The urine osmolality will be low, and that's because you are not reabsorbing water. So even though you're not reabsorbing sodium, the fact that you're not reabsorbing water is going to drive your urine osmolality down. And with the tubulointerstitial diseases, your urine osmolality should be roughly the same as your serum osmolality, isostenuria. That's what that's called. And then your BUN creatinine is going to be roughly 10 to 1. We're not reabsorbing BUN either. So your BUN creatinine ratio should be right around 10 to 1. What's going to be most prominent with tubulointerstitial diseases are these casts or sediments that you find in the urine. So with acute tubular necrosis, you'll find brown casts or epithelial casts, and I got a picture of that I'll show you in a little bit. With acute interstitial nephritis, you can find eosinophils, and you'll need to do a particular stain for that.
So here's 9 of the tubulointerstitial diseases we're going to talk about. The two most important ones are acute tubular necrosis and allergic interstitial nephritis. They account for a large majority of the tubulointerstitial diseases. We'll talk about renal insufficiency mediated by toxins. We'll talk about atheroembolic disease of the kidney, pigment-mediated renal insufficiency secondary to multiple myeloma, crystal-mediated renal insufficiency secondary to hypercalcemia, and then the papillary necrosis. So acute tubular necrosis is ischemic hypoperfusion of the kidneys, particularly the tubular cells. So remember, we talked about hypoperfusion to the kidneys as being a cause of pre-renal failure. That's just less blood going to the kidneys. The kidney tissue itself is getting enough blood, though, to reabsorb and to function. It's just the kidney is sensing less blood in pre-renal failure, so it's getting less blood. On the other hand, more severely in acute tubular necrosis, we're getting so little blood to the kidneys that we actually have ischemia. And so the tubules, tubular cells in the kidneys actually can't function because they're not getting enough oxygen. So it's more severe. And so because we have ischemic hypoperfusion, the tubular cells can't function. So the symptoms, like in all renal failure, will be azotemia as an incidental finding, and if it's severe enough, we'll have uremia, which will be characterized as mental status changes, possibly edema, fatigue, nausea, vomiting. The diagnosis for acute tubular necrosis, the first place we're going to go is the urinalysis. And our urinalysis is going to show tubulointerstitial disease. It's going to show a high urine sodium, a high fractional excretion of sodium, and a low urine osmolality. In acute tubular necrosis, because our tubular cells are ischemic, they're going to slough off and die. So our urinalysis will show the result of that, which are dead endothelial tubular cells, and they appear as what's called muddy brown casts, and we'll take a look at this. Anytime we want to diagnose acute tubular necrosis, of course, the first thing we do is urinalysis, but we should also get a CMP to assess the potassium, because remember that our tubules are responsible for secreting potassium. We don't want to have too high of a potassium, and our kidneys are responsible for getting rid of excess potassium. So anytime we have a renal disease, we always want to make sure we're on top of our potassium levels to ensure that the patient is stable. And if the potassium levels are high, then we want to get an EKG. And we're going to be, of course, looking at the EKG for the peaked T waves, which is a sign of hyperkalemia. We also want to get a CBC in any patient with renal disease because we want to check for our white blood cells, and we want to check for anemia. So the treatment for acute tubular necrosis, unfortunately, we don't have any acute therapy for acute tubular necrosis because the kidneys don't work. So we can't really do anything for the kidneys. What we can do is observe the patient, so we admit them, and we're going to monitor their electrolytes, namely the potassium, with serial CMPs, and we're going to observe them for any symptoms that may be secondary to their uremia. And if they develop significant uremic complications, such as very high potassium with EKG changes, pericarditis, encephalitis, GI bleeds, then they're going to need dialysis. So these are our muddy brown casts that we talk about, all this brown matter here, and these big brown cells here, these are just dead epithelial cells. Some of this little stuff is bits and pieces of cells, but you could see some larger chunks of epithelial cells here. And so this is pathognomonic of acute tubular necrosis. You just have tubular cells that are dying and they're falling off and going out in the urine, and these muddy brown casts are the tubular cells in the urine. Okay, now allergic interstitial nephritis is different. So there's many causes of allergic interstitial nephritis, the most common of which is drugs, but it can also be caused by infections and autoimmune disorders. When we think about drugs that cause allergic interstitial nephritis, the best way to think of it is ABCQRS. So allopurinol, penicillin, which I know starts with P, but you can think of it as B, it sounds the same. So allopurinol, penicillin, cephalosporins, so any of the 4 generations of cephalosporins, quinolones, rifampin, which is used in TB, and sulfas. So a big wide range of drugs. These are also the drugs that people are most commonly allergic to. So when you have patients that come in and they say they're allergic to drugs, what do they say they're allergic to? They're allergic to penicillin. They're allergic to sulfa drugs. Infections, pretty much any infection can cause allergic interstitial nephritis, but drugs are going to be the most common cause. So here we're going to see a patient possibly with uremic symptoms or azotemia on labs. But what's going to be more prominent is that these patients present with a fever and a rash, and that's going to be what they come in for. They have a fever and a rash, and you're going to think, oh, okay, they started on this drug, and shortly after they started on this drug, they got a fever and a rash. You're going to want to check a urinalysis on any patient that presents like this because allergic interstitial nephritis is a possible result. Now, what are you going to think of first when you see a patient that takes one of these drugs and develops a rash? You're going to think of just a simple allergic reaction. But you're going to want to get a urinalysis on any patient that starts a drug and then shortly presents with a fever and a rash because allergic interstitial nephritis is a possibility. So a urinalysis is the diagnostic test of choice when you suspect allergic interstitial nephritis. So you suspect allergic interstitial nephritis when a patient just started on a drug and now they have a fever and a rash. And a fever is a lot less common in just a simple allergic reaction. And on the urinalysis, you're going to see an elevated white blood cell count. And that would be very unusual in just a simple allergic reaction. You can also get a CBC, and their CBC will show eosinophilia, but urinalysis would definitely be the best test of choice for diagnosing allergic interstitial nephritis. Now, in patients, when you get a UA and you see white blood cells, it's not going to tell you what kind of white blood cells they are. So to definitively diagnose allergic interstitial nephritis, you have to stain the urine with what's called a Hansel stain, and that is specific for eosinophils. So you can usually put it together if a patient comes in, they just started an antibiotic, now they got a fever and a rash, and their urinalysis comes back positive for white blood cells, and they don't have any other symptoms of a UTI. You can usually put that together as allergic interstitial nephritis, but to definitively diagnose allergic interstitial nephritis, you have to know that those are eosinophils. And so you have to do a Hansel stain on the urine. And the treatment here is like any allergic reaction to simply stop the offending agent. And you admit the patient and observe them for 3 days to monitor their electrolytes and their renal function. And if the renal function, if the renal failure persists after 3 days, then you can start IV prednisone, and that will usually abate the allergic interstitial nephritis. But generally, stopping the offending agent will be enough. So toxin-mediated renal insufficiency is similar to allergic interstitial nephritis in that it's caused by drugs. However, unlike allergic interstitial nephritis, toxin-mediated renal insufficiency does not happen after the first dose. Toxin-mediated renal insufficiency is a cumulative effect of toxic drugs. So the particular toxins that we're going to see with toxin-mediated renal insufficiency are the NSAIDs, the aminoglycosides such as tobramycin, amikacin, amphotericin B, cisplatin, cephalosporins, contrast, and cyclosporine. So here we're going to see uremic symptoms or incidental azotemia following longer-term therapy. So this isn't going to be like allergic interstitial nephritis where we see the symptoms immediately within a day after starting the drug. We're going to see this several days to weeks after starting the drug. And it's going to be more long-term, less acute. And most importantly here, it's going to be associated with a drug, but there's not going to be any fever or any rash because this is not an allergic reaction. This is toxic, directly toxic to the tubular cells. And so this is a diagnosis of exclusion. We're going to want to exclude any other kind of renal failure. And we also have to find and know what the specific toxin is in order to diagnose it. And like I said, the most common causes are NSAIDs and aminoglycosides. You also keep an eye out for the antifungal amphotericin B, the chemotherapeutic drugs, cisplatin, the antibiotics, so the cephalosporins, and then contrast and the cyclosporine. So treatment is generally dependent on the drug. Like I said, aminoglycosides are a very common cause of toxin-mediated renal insufficiency. And the best way we can prevent toxin-mediated renal insufficiency when we're using aminoglycosides for patients is to ensure wide spacing of doses. So we don't want to give aminoglycosides to patients TID, twice a day or 3 times a day, 4 times a day. We want to give them their aminoglycosides once a day if possible. So we want to spread out those doses of aminoglycosides. If we're giving the patient contrast for radiologic procedure, then we're going to want to make sure that we prehydrate them, and we can also give them N-acetylcysteine. And most of these renal insufficiencies are going to abate when the course of the drug is completed. So I talked about contrast just a little bit ago, and contrast is a common cause of renal insufficiency, particularly in patients that are diabetic, older, or have pre-existing renal disease. We have to be really careful when we use contrast in these patients. And the reason is because, one, it is toxic, and two, it does cause vasospasm of the afferent arteriole. So remember, vasospasm of the afferent arteriole will reduce blood going to the kidneys, and so that can actually cause a pre-renal picture, and so that's going to be what you'll have initially, and then the contrast, as it is in the blood longer, will cause a evolution into an ischemic and tubular interstitial picture. So think of contrast as causing both pre-renal and tubular interstitial disease. And so either way, the way we treat this is by prevention. And we want to prevent renal insufficiency by giving generous IV hydration and N-acetylcysteine prior to the administration of contrast. So just a very important clinical thing to know before you give any patient contrast before their CT. Atheroembolic disease of the kidney is a very easy one to suspect because these patients will develop multiple small infarctions of the renal parenchyma and usually of other parts, especially their skin, after a recent vascular procedure. So you might do an angiogram on these patients, and then a couple days later they start developing blue patches on their skin, vascular congestion, and then symptoms of renal failure. The most prominent of the vascular congestive symptoms is going to be something called Livedo reticularis. So the diagnosis here is going to be retrospective and clinical. We're going to rule out other possible causes of renal failure. But that history of a recent vascular procedure followed by renal failure is going to be very suggestive, especially in the presence of vascular congestion like Livedo reticularis. And unfortunately, there's no treatment for these patients. So let's take a look at Livedo reticularis. Very, very prominent in this patient here. Ignore this arrow, it's pointing to something else. But this is Livedo reticularis. You see it on the lower extremities, and you see it on the upper extremities. You can see this on yourself if you go outside in the cold and then come back in. All it is vascular congestion. When you go outside in the cold, the blood in your capillaries slow down, and that's what actually is causing this kind of mottling of the skin. But in patients with atheroembolic disease, it's not just the blood slowing down, you're actually getting embolisms to the capillaries. And so the blood's not only slowed down, it's stopped. And that's what the Livedo reticularis is. Here's another patient where it's pretty prominent in the lower extremity. And this is a little less prominent here, but it's still very clear mottling. So pigment-mediated renal insufficiency, more so we're going to think of this as rhabdomyolysis. So pigment-mediated renal insufficiency can be caused by myoglobin or hemoglobin. Usually it's going to be myoglobin in the presence of rhabdomyolysis. The only time it's going to be hemoglobin is when you administer blood to a patient, a blood transfusion, and it's the wrong ABO type. And that's going to cause a disbursement of hemoglobin, which is toxic to the kidney. But myoglobin is much more common, and it's myoglobin in the setting of rhabdomyolysis. So when you have a patient with rhabdomyolysis, what you have is a patient who's just had their leg run over by a car, or they've had status epilepticus, and they've had seizures, and their muscles have tensed up. And what's common in both of these is that the muscle has deteriorated. And what's inside muscle? Well, there's two things. We got myoglobin, and myoglobin is toxic to the kidney, and we have potassium. Remember that almost all of our potassium is intracellular. So when cells break down, our potassium level in our blood is going to go up, and it can go up significantly. And so, because in rhabdomyolysis we can get precipitous increases in our serum potassium, the most important thing to do in any patient where we suspect rhabdomyolysis is to protect the heart. And how do we protect the heart? We get an EKG and a CMP. More importantly, the EKG. So we're getting an EKG to check the heart, and we're getting a CMP to check the potassium level. If we have a patient who's got an EKG that shows spiked T waves characteristic of hyperkalemia, and they indeed also have a high potassium, then we're immediately going to want to administer calcium gluconate. If, let's say, they have rhabdomyolysis and their EKG and CMP are fine, or their CMP shows moderately high potassium with no changes on EKG, then we're not as worried about the heart at that point. Doesn't mean we're not going to continue to check. It just means at that point, then we're reassured that the heart is okay for now. At that point, then we're going to want to get a urinalysis to check for myoglobin. And the urinalysis, we're not actually checking particularly for myoglobin. What we're doing is we're going to check the urinalysis for red blood cells. The red blood cells will be positive. And what the red blood cell is on a urinalysis is just hemoglobin, just heme. So because myoglobin has heme in it, it will show quote-unquote red blood cells. But red blood cells on a urinalysis could be myoglobin or hemoglobin. So in the presence of a patient where we suspect rhabdomyolysis and they do have red blood cells positive in their urinalysis, then we're going to suspect, okay, this is myoglobin. And so what do we do when we to confirm rhabdomyolysis? We get a CPK level. So another way we can know on the urinalysis that it's indeed myoglobin and not hemoglobin is that the patient will have positive red blood cells, but the red blood cells won't show up on microscopy. That's another way that the USMLE might pose it to you. But if it's a patient that has suspected rhabdomyolysis because they had status epilepticus or seizures, or they had a crush injury, and then you see red blood cells on the urinalysis, then you can pretty much safely assume that that's myoglobin. But we always have to confirm this with a CPK level, and the CPK level will be high. So these patients, we're going to want to admit them to the ICU. We're going to, if they do have high potassium and high EKG changes, which will be the peaked T waves, we're going to administer calcium gluconate, which will reduce their serum potassium levels. We want to hydrate these patients generously and give them osmotic diuretics. What does that do? That increases urine flow. Why do we want to increase urine flow? Because myoglobin, when it's inside the kidneys, is directly toxic on contact with the tubular cells. So the faster we can get fluids through these patients and flush out their kidneys, the faster we're going to get the myoglobin through and the less permanent renal damage we're going to have. We're also going to want to alkalinize these patients with sodium bicarb. This also will reduce the likelihood of chronic renal damage. So renal insufficiency secondary to multiple myeloma. The cause is, so in multiple myeloma, what we have is a pathologic B-cell clonal population. And this B-cell clonal population secretes something called Bence-Jones proteins, which is just immunoglobulins, which is filtered through the glomerulus and causes tubular damage. So this is a pretty easy one to suspect because the patient is going to be a patient with multiple myeloma or signs of multiple myeloma, and then they'll also have uremic symptoms or azotemia found on labs. The diagnosis for these patients to determine that it's renal insufficiency secondary to multiple myeloma is to get a 24-hour urine protein. A urinalysis will not detect Bence-Jones proteins because it's such a small protein. The urinalysis is more to find larger proteins. So we don't find Bence-Jones proteins on urinalysis. So any patient with multiple myeloma where we're suspecting renal insufficiency, we want to get a 24-hour urine protein on these patients. And the treatment here, unfortunately, there's no specific therapy. We're going to have to continue to treat their multiple myeloma. We want to give them observation to monitor their renal function, and if they start developing severe symptoms of uremia, like mental status changes, acidemia, electrolyte abnormalities with EKG changes, fluid overload, or other uremic complications such as pericarditis, encephalitis, or a GI bleed, then these patients are definitely going to need dialysis. Crystal-mediated renal insufficiency are most commonly caused by oxalate and urate stones, and you're usually going to see these in patients that either have cancer and are getting chemotherapy, or in patients that just attempted to commit suicide by drinking antifreeze, which is ethylene glycol. Occasionally, you can see oxalate stones in patients with Crohn's disease, but most commonly, when you see those envelope-shaped oxalate stones, it is due to ethylene glycol ingestion because of a suicide attempt. So, urate stones are going to be diamond-shaped, and you'll usually know that they're going to be urate stones because they'll be diamond-shaped and because the patient will be on chemotherapy. So, what do we do to find out if it's crystal-mediated? Well, one, you're going to want to get a urinalysis. Because that's the only way we're going to find the stones. The symptoms, it's just simply going to be uremia. In oxalate stones, it's going to be very acute because these patients just took ethylene glycol. And particularly in ethylene glycol, you're going to see an elevated anion gap metabolic acidosis. So remember how to calculate our anion gap, which is just simply the difference between sodium and the chlorine and bicarb. So we add our cations, which we can usually ignore potassium because it's so low relative to the others, and then we subtract the sum of chlorine and bicarb. And if that difference is 11 milliequivalents per liter or more, then this patient has an elevated anion gap. And if they are acidotic, then we consider that an elevated anion gap metabolic acidosis, which is something we're going to see in oxalate poisoning. So the diagnosis is going to be based on history and, as I mentioned, urinalysis. History is going to be pretty conspicuous. Either the patient has a sweet odor on their breath and found unresponsive, and the patient has a history of suicidal intent or behavior, major depression, etc. That's going to point towards your ethylene glycol, and or the patient may be undergoing chemotherapy. That's going to point towards urate, but you're going to have to get a urinalysis and see stones. Oxalate stones look like envelopes. Urate stones look like diamonds. So the treatment for both of these is going to be hydration. We want to get those stones flushed out. And for oxalate, for oxalate stones, we're going to give either IV ethanol or IV fomepizole, and we're going to dialyze these patients. For urate, we're going to alkalinize these patients with sodium bicarb. So in oxalate crystals, why do we give IV ethanol? And that might sound strange because you're thinking IV ethanol. Isn't that like giving a patient vodka? And yes, it pretty much is. So why do we give ethanol? These patients, when they have the ethylene glycol in and of itself is not dangerous by itself. It's dangerous when it's converted into glycoaldehyde and into glycolic acid, and then subsequently to oxalic acid by this series of enzymes: alcohol dehydrogenase, aldehyde dehydrogenase, lactate dehydrogenase, and xanthine oxidase. Alcohol dehydrogenase is a very, very, very common enzyme that's used. It's used in multiple different pathways. As you can see here, it's also used for methanol, which doesn't cause renal symptoms. It causes blindness, but it's also used by ethylene glycol, and it's used by ethanol, which is your basic drinking alcohol. And so what we do is when we give these patients IV ethanol, we're going to supersaturate these alcohol dehydrogenase enzymes, and so we're going to prevent ethylene glycol from being converted into glycoaldehyde, etc., all the way to oxalic acid, and prevent more stones from being created. And we're doing this at the same time we hydrate the patient and the same time we dialyze the patient so that we can both prevent the stones from forming and get the ethylene glycol directly out of the blood. So it's a three-pronged approach. But IV ethanol will competitively inhibit alcohol dehydrogenase, or competitively inhibit ethylene glycol by saturating the alcohol dehydrogenase. And that's why we use IV ethanol. Renal insufficiency secondary to hypercalcemia. The cause here is going to be precipitation of calcium stones, and that's simply due to a high level of serum calcium. And what's our most common reason to have high serum calcium? It's going to be because you have hyperparathyroidism. So like all renal insufficiencies, you're going to have presenting uremic symptoms, and then you're also going to have in hypercalcemia with uremic symptoms, you'll usually have symptoms of hyperparathyroidism. So hyperparathyroidism increases your parathyroid hormone, which increases your calcium, and the way we increase the calcium with parathyroid hormone is that we increase the activity of osteoclasts, which break down bone. So breaking down bone will cause bone pain, and breaking down bone will cause our bones to be more brittle and cause osteoporosis. So bone pain and osteoporosis are two symptoms of hyperparathyroidism. Abdominal pain will be caused directly due to the calcium. Constipation, polyuria, polydipsia, and nausea and vomiting are also symptoms of hyperparathyroidism. So the diagnosis is going to be uremic symptoms in a patient with hyperparathyroidism, and that will be pretty clear that our calcium is causing their uremic symptoms. And patients with hyperparathyroidism are to be advised that they can go into kidney failure, and so these patients will usually come in knowing that they have possible kidney failure because of their uremic symptoms. So if the patient hasn't been diagnosed yet with hyperparathyroidism, then we're going to want to establish that diagnosis if we're suspecting hyperparathyroidism because they have the bone pain and osteoporosis, etc. And so we can diagnose this by getting a sestamibi scan, which is a nuclear test to look at the parathyroid glands that are causing the hyperparathyroidism. And we can also get parathyroid hormone levels. But generally, on the USMLE, you're going to be given a vignette where the patient has been diagnosed with hyperparathyroidism, or you're given labs that show that they have hyperparathyroidism, and then they present with uremic symptoms and lab abnormalities that show renal insufficiency. So the treatment, anytime you have a patient with hyperparathyroidism, and they develop decreased renal function, then these patients have an absolute indication for parathyroidectomy, which is surgical treatment, and it's simply the resection of the parathyroid glands. Okay, papillary necrosis. So papillary necrosis comes up in patients with diabetes mellitus, cirrhosis, and sickle cell disease. Those are the three more common diseases. It can be in other diseases as well. But those are the three to keep in mind: diabetes mellitus, cirrhosis, and sickle cell disease. And it's following the ingestion of acetaminophen, which is Tylenol, or NSAIDs. And so this is going to appear like a UTI. These patients are going to have fever and flank pain. And it's not a big surprise that they have fever and flank pain, because literally the papules of the kidney, the papilla, are literally melting and dying right into their ureters. And so they've got pain in their flank, and it makes perfect sense. So patients with diabetes mellitus, cirrhosis, or sickle cell, after the ingestion of acetaminophen, they get UTI-like symptoms, and so we want to get a UA. Why do we want to get a UA? Because when you're actually working in the hospital and you're really thinking about what's the most common thing that causes fever and flank pain, you're going to think a UTI. And so, because the patient has fever and flank pain, just because they took acetaminophen does not necessarily mean jump to papillary necrosis. Papillary necrosis is much more rare than a UTI. So when a patient comes in with fever and flank pain, you want to get a UA. If the UA shows white cells and elevated nitrites, then fine, diagnose a UTI. But if the patient has fever and flank pain, also happens to have diabetes mellitus, cirrhosis, or sickle cell disease, and it was following the ingestion of acetaminophen, and surprisingly they have no white blood cells or elevated nitrites on their UA, then you're going to think, okay, this is probably papillary necrosis, and you're going to want to confirm papillary necrosis with a spiral CT. That spiral CT will indicate papillary necrosis, and what we do is, of course, we stop the offending agent, which would be either our acetaminophen or our NSAIDs, and in this case, we really have no specific therapy. So we're going to just want to stop the offending agent and have some watchful waiting. We'll probably admit the patient. Patients with risk factors such as diabetes mellitus, cirrhosis, or sickle cell disease should be advised to avoid excessive use of acetaminophen and NSAIDs, particularly in patients with sickle cell disease because they can come in with their pain crises due to occlusion, vaso-occlusion. We don't want them using acetaminophen or NSAIDs, so these are the patients that when they come in with pain, we do want to go straight to the narcotics. So let's just go over an overview of all of these disease processes we covered. So here I've got the disease process written out for you, and then some specifics. So all of these are going to presumably present with renal failure, with uremia, or with incidental azotemia. But these are going to be some specifics to look for that's going to point you towards these specific disease processes. We've got our diagnostic tests over here, and then our treatment. So acute tubular necrosis, you're not going to have any specific symptoms. You're just going to simply have uremic symptoms. We're going to diagnose this with a urinalysis, which will show muddy brown casts. Our treatment is going to be nothing. We're going to have to monitor these patients, and they may need dialysis. Allergic interstitial nephritis will be immediately after a drug, and these patients will have fever and a rash. Diagnostic tests will be urinalysis, which shows white blood cells, but we don't know what kind of white blood cells those are, so we're going to want to get a Hansel stain. Treatment for these patients is going to be to monitor and admit. Admit these patients after 3 days. If they don't improve in their renal functions, then you can start IV prednisone. A toxin-mediated renal insufficiency, these patients are going to be on specific drugs, especially aminoglycosides or contrast. But unlike allergic interstitial nephritis, which are also on drugs, these patients are not going to have a fever and a rash, and this is not going to happen immediately. This is due to toxins, not due to an allergic response. There's no diagnostic test. It's diagnosed on history and on exclusion, and the treatment is going to be dependent on the drug. For aminoglycosides, we're going to want to space out the doses, and for contrast, we're going to want to hydrate these patients and give them N-acetylcysteine. For atheroembolic disease of the kidney, we're going to be led to this because these patients have recently had an invasive vascular procedure, and a lot of times we'll see that Livedo reticularis, which is that modeling of the skin. And there's no diagnostic test for this either. It's generally going to be pretty clear because the patient had an invasive vascular procedure that's almost always necessary for this disease process. And the modeling and the skin symptoms and blue skin are going to be also very, very, very specific to atheroembolic disease. And there's no treatment here either. Pigment-mediated renal insufficiency, which is almost always in the setting of rhabdomyolysis. The specifics is going to be, it's going to usually follow a crush injury or a seizure, and these patients will have an elevated potassium in almost all cases. The first step is always going to be to protect the heart. We're going to want to get a potassium level and an EKG. If the potassium is high and the patient has peaked T waves, then we're going to want to administer calcium gluconate. If the patient, after we give them calcium gluconate, or if they don't have high potassium and EKG changes, then we're going to want to make sure we flush out the myoglobin by giving them generous hydration and sodium bicarb. And of course, we confirm our diagnosis of rhabdomyolysis with CPK levels. But if the patient has a crush injury, don't wait around for those CPK levels. Get your potassium level and EKG first, because these patients are in severe danger of going into acute cardiac failure. Renal insufficiency secondary to multiple myeloma. Of course, these patients will have multiple myeloma. Diagnostic test is going to be the 24-hour urine protein, because a simple dipstick is not going to tell you what kind of protein is in the urine. It's not going to tell you if it's Benz-Jones protein. Benz-Jones protein is not detected on urine dipstick, so we want to get a 24-hour urine protein. There's no treatment for renal insufficiency secondary to multiple myeloma. Renal insufficiency is unfortunately one of the major causes of death for multiple myeloma. So we really just need to monitor these patients, and they're probably going to need dialysis at some point. Renal insufficiency secondary to hypercalcemia. These are going to be patients that already have diagnosed hyperparathyroidism, and or they have bone pain, osteoporosis, abdominal pain, constipation. To diagnose these patients, it's going to be clinical based on history. If they have not had hyperparathyroidism as a diagnosis, then we can get a sestamibi scan and parathyroid hormone levels. And in any patient with hyperparathyroidism that develops renal insufficiency, that is a surgical indication for a parathyroidectomy. And then finally, for papillary necrosis, the specifics here is going to be UTI symptoms with, once you get the UA, you're going to see no elevated white count, no elevated nitrites, which are going to be what we expect in a UTI. So you have UTI symptoms without the UTI lab values. And so these are also going to be patients that have those common three disorders: sickle cell disease, diabetes mellitus, and cirrhosis or liver disease. Once we get that UA in these patients and they have these UTI symptoms but no elevated white cells and no elevated nitrites, etc., then we can start suspecting papillary necrosis, and the definitive diagnosis for papillary necrosis is a spiral CT. And the treatment for papillary necrosis is to stop the offending agent, which is most commonly NSAIDs. And that is the end of tubulointerstitial disease.